नमस्ते बिटिया, हमेशा खुश रहो बेटा। A very good morning to you all. Myself, JBN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, Faculty of Homeopathic Science at JAYOTI Vidyapeeth. In this series of respiratory diseases, today we will be discussing about tuberculosis. The tuberculosis will be discussed in two parts. This is the first part of tuberculosis, in which we will discuss about the definition, the etiopathogenesis, the clinical features, and the investigation of tuberculosis. And in the second part, we will be discussing about the management of cases of tuberculosis. So let's start with tuberculosis. Tuberculosis is caused by the infection of Mycobacterium tuberculosis. Mycobacterium tuberculosis is a rod-shaped, non-spore forming, thin, aerobic, and acid-fast bacilli. Mycobacterium bovis, it has reservoir in the cattle. Mycobacterium africanum has the reservoir in human beings. Around 1/3 of the world population has latent tuberculosis. This disease most often affects the lungs, although other organs are involved in up to 1/3 of the cases. Mycobacterium bovis arises from drinking non-sterilized milk from infected cows. Mycobacterium tuberculosis is spread by inhalation of aerosolized droplet nuclei from the other infected patients by coughing, sneezing, or speaking. The organism lodge in the alveoli and initiate the recruitment of macrophages and lymphocytes. What is the pathogenesis of tuberculosis? The macrophages undergo transformation into epithelioid and Langerhans cells, which aggregate with the lymphocytes to form the classical tuberculous granuloma. The normal tissue is lost and replaced by a mass of fibrous tissue with granulomatous inflammation characterized by the presence of large number of macrophages and multinucleate giant cells. Numerous granulomas aggregate to form primary lesion or gone focus. A pale yellow caseous nodule, usually a few millimeter to 1 to 2 centimeter in diameter, which is characteristically situated in the periphery of the lungs. The combination of a primary lesion and regional lymph nodes is referred to as primary complex of Reinke. The lesion eventually calcifies and is clearly seen on a chest X-ray. Secondary foci in other organs includes lymph nodes, serous membrane, meninges, bones, liver, kidneys, and lungs. Infection has occurred may be the appearance of a mediated delayed type hypersensitivity to tuberculin demonstrated by tuberculin skin test. This is going to be done. Clinical features of pulmonary disease. The infection of previously uninfected tuberculin negative individual. There is a self-limiting febrile illness. Influenza-like illness. Skin test conversion. Primary complex. Lymphadenopathy. Consolidation. obstructive emphysema, pleural effusion, erythema nodosum. The clinical features of biliary tuberculosis: blood-borne dissemination, 2 to 3 weeks of fever, night sweat, anorexia, weight loss, dry cough, chest X-ray. In the chest X-ray, there is a classical appearance of fine 1 to 2 millimeter lesions that are called as millet seed lesions. Anemia and leukopenia that reflect the bone marrow involvement. Post-primary tuberculosis: exogenous new infection or endogenous reactivation of the dormant primary lesion infection in a person who has been sensitized by earlier exposure. Most common, it occurs in the apex of upper lobe, where the oxygen tension favors survival of a strictly aerobic organism. Insidious onset, developing slowly over several weeks. Systemic symptoms includes fever, night sweat, malaise, and loss of appetite and weight. Post-primary pulmonary tuberculosis: there is chronic cough, often with hemoptysis. There is pyrexia of unknown origin. Unresolved pneumonia, exudative pleural effusion. It can be asymptomatic, and the diagnosis is done on the basis of chest X-ray. There can be weight loss and general debility. There can be spontaneous pneumothorax. There are various radiological changes which consist of ill-defined opacification on one or both of the upper lobes. And as the progression occurs, there is consolidation, relapse, and cavitation to varying degree. The clinical features in case of extrapulmonary disease: there can be lymphadenitis, gastrointestinal disease, pericardial disease, central nervous system disease, bone and joint disease, and genitourinary disease. There are various clinical features of extrapulmonary disease, which includes headache, vomiting, seizures, confusion, lymphocytic meningitis, hydrocephalus, space-occupying lesion, that is tuberculoma. There can be chronic back pain, kyphosis, cord compression, abdominal mass, psoas abscess. General observation consists of weight loss, fever, night sweats, cranial nerve palsy, lymph node enlargement, pericardial effusion, constrictive pericarditis, exudative ascites, mesenteric adenitis, intestinal obstruction, hematuria, dysuria, infertility in women, epididymitis, monoarthritis, anorectal ulcerations. How will you diagnose the case of tuberculosis? Unexplained cough for more than 2 to 3 weeks, particularly in an area where tuberculosis is highly prevalent. Direct microscopy of sputum. In the next topic, we will be discussing about the therapeutics of tuberculosis. So this was all about tuberculosis, the definition, the etiopathogenesis, the clinical features, and investigations. And in the next lecture, we will be discussing about tuberculosis therapeutics. This session was powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any problem or any query, please mention it in the comment box. I will try to resolve. Thank you very much. So this was all about tuberculosis. I hope you have understood something from it. And in the next lecture, we will be talking about the therapeutics of tuberculosis, both the modern medicine as well as the medieval medicines.